started, I'm just going to run through a few quick housekeeping pieces for you. First of all, you may have all noticed that you are muted. Everyone is muted upon entry. That's just to cut back on feedback and different background noises throughout the presentation. You'll remain muted throughout the course of the presentation. There will be a short question and answer session at the end of the presentation. If you have any questions that you'd like to pose to any of our presenters, you can feel free to chat them to me, the host, via the chat function, and I will relay the questions to the presenters that you would like to open a dialogue with. So those are the only housekeeping pieces. I'm now going to turn the presentation over to Dr. Esther Dyer, who's the CEO and President of National Medical Fellowships. Dr. Dyer?
Thank you, Sam, and thank you all for joining us today. On behalf of National Medical Fellowships, I want to extend our sincere congratulations to all of this year's PCLP scholars and to all of our partners in the Primary Care Leadership Program. We're thrilled to convene our annual Kickoff webinar, which officially launches the PCLP summer season. This is the 5th year of PCLP, and it's going to be our best yet. We're grateful to the GE Foundation for its continuing support and to all of our partners and faculty who make the program possible. National Medical Fellowships is proud to partner with the GE Foundation in what Dr. Jack Geiger has called a transformational opportunity to introduce you to future careers in primary care. It's an opportunity to work with some of the outstanding leaders in community health centers at a critical moment in the history of these organizations. In the era of healthcare reform and also in a time when we continue to face a daunting primary care crisis in increasingly complex and ever-changing environments. You'll learn from these leaders on how they are innovating in challenging times, and you'll learn from academic mentors or on the cutting edge of partnerships with community health centers to improve delivery for medically underserved communities. Most importantly, you'll learn about and you'll witness firsthand the commitment and passion that drives these leaders, providers, and educators to continue the hard yet rewarding work of providing the highest quality care for populations that need it most. You'll have opportunities to investigate, explore, and most importantly, to contribute. I look forward to meeting you in Chicago and to hearing about your success this summer. So this year marks National Medical Fellowship's 70th anniversary, and we are enormously proud as an organization that was founded in Chicago that we'll all be together there, but also that through the years we've been able to support 30,000 scholarships. And I want to introduce one of our most distinguished alumni, and in Dr. Sandra Nichols. She's a truly distinguished individual, a long-standing and treasured friend, and most importantly, she serves on the board of National Medical Fellowships as our vice chair and has been an active member of the PCLP National Advisory Committee since 2012. Her day job is as Chief Medical Officer and Senior Vice President of National Inpatient Care Management for United Healthcare, and she was previously Chief Medical Officer of the Western Region and Western and National Medical Director for United Healthcare. She has more than 20 years of increasingly responsible roles, and she was a former director and commissioner of the Arkansas Department of Health and a cabinet secretary and board of health member in the administration of 2 Arkansas governors, Jim Guy Tucker and Mike Huckabee. She's held a number of other responsible positions and increasingly through her career has sought to increase health equity for those that she touches and those that she advocates for. She also serves by the appointment in 2012 of Catherine Sabellas, the Secretary of Health and Human Services, a 4-year term on the National Advisory Council on Nurse Education and Practice of the Health Resources and Service Administration. I ask you to welcome Dr. Sandra Nichols. and we look forward to a wonderful seminar. Thank you all, and thank you, Sandra, for serving as our moderator today.
Thank you very much, Dr. Dyer. It is an honor and a privilege to serve as your moderator today. Our primary care leadership program that is sponsored by our partners at the GE Foundation is one of the key programs that our National Health Foundation has had the distinct honor of being a part of and to work with. Our GE Foundation partners are true to their word that they want to build a world that's work better for individual citizens, and to understand that they are building this world not only within the United States but globally. I am a formal director and employee of the community health centers down in this great state of Arkansas, and obviously spent some quality time with them when I directed and served as the Commissioner of Health for the Arkansas Department of Health, and they are at the core of healthcare to the underprivileged and the underserved. So it is an honor and a privilege to be a part of this meeting today and to be your facilitator. Let's do a little bit of cleanup here today to make sure that we're all on the same page. Just a little bit of house cleaning. Of course, the greeting, I get to introduce Jennifer Edwards, our GE Foundation, who's going to talk about and do the program overview and welcome each of you to our meetings today. Then we're going to do the American Community Health Center History and Progress by Don Weaver. After Don will be the Community Health Center and Healthcare Innovation by Bruce Gray, and significance of the PCLP experience will be done by Gianna Ramos. And I will then begin a question and answer initiative as a part of this meeting. I will ask that you hold your questions until the end, and that we're going to do our best to stay on target today. Again, thank you for your presence today. Thank you for all that you do. And let me start by introducing our partner, Jennifer Edwards. Jennifer joined GE in 1998 as a healthcare manager for GE Capital. She was at that time responsible for the U.S. healthcare strategy and preventive care initiative. For the last 15 years, she has held various HR positions at both GE Capital and GE Corporate with increasing responsibility and a global perspective. She is a Six Sigma certified and has extensive knowledge and extensive experience in employee benefit with a focus on healthcare benefits and initiatives, program management, and operations. Thank you. In 2010, she assumed the role of program lead for GE Volunteerism under the GE Foundation. In that role, she has overseen the global network of GE volunteers whose mission is to improve the communities where GE people live and where they work. She has developed relationships with global client groups, implemented a worldwide strategy, and created the operating infrastructure, all of which the goal of driving corporate citizenship and employee engagement around the globe. Prior to joining GE, Jennifer had extensive experience in the healthcare sector, working in both the regional and national markets where she managed a portfolio of Fortune 500 clients. And believe it or not, Jennifer not only has a BA degree from the University of Vermont, but she currently lives in Stamford, Connecticut, where she lives with her husband and 4 children. Jennifer, it is an honor and a privilege to welcome you to the meeting today and to hear from you at this time.
Thanks so much for that introduction. Hello, everyone. Jennifer Edwards here. I'll be brief. I just wanted the opportunity to address you all from a GE Foundation perspective, just so you can hear the excitement in my voice and the passion that I have for this program. As Esther mentioned, you know, I lead the foundation here in the U.S. Its health portfolio, which is about 6 years old and has always been focused around improving access to quality care for underrepresented populations, and we've been steadfast supporters of community health centers. So, as Joy will attest, the Primary Care Leadership Program is one of my favorite programs here at GE. We're entering our 5th year. We have put upwards of 300 scholars through this program, and you know, when we take a look at what's our measure of success, right? We want you in this program because we really want to seed that pipeline of not only primary care, but diverse candidates in primary care, because we want to start changing the face of medicine. So if we take a look at the cohorts as we follow them through their journey, their academic journey, 83% are choosing primary care as a postgraduate focus. So we are just thrilled about this. I really like this program. I think you all have so much to look forward to. There's so many prongs and legs to this program, from the leadership development to the clinical experience to the research and the project that you are going to lead within each of the organizations. So all I can say is make the best of it. Take every opportunity you can to link with those leaders at those health centers, because they are very open to being mentors, to guide you, because they realize that scholars such as yourselves are really the next generation of leaders for these health centers. So I very much look forward to meeting each and every one of you in Chicago in July. And until then, best of luck, and enjoy it and have fun.
Jennifer, thank you and the Foundation for your commitment to the communities and commitments to the PCLP program and our students, and very much so appreciate your comments. Next, we get to introduce a Rear Admiral and a physician. Rear Admiral Donald L. Weaver has served as the Acting Surgeon General of the United States and hence as Operational Commander of the Commissioned Corps of the United States Public Health Services, which is a uniformed force of over 6,000 health professional officers who are dedicated to promoting, protecting, and advancing the health and safety of the people of the United States and around the world. Prior to his appointment as Acting Surgeon General, he served as the Deputy Associate Administrator for the Primary Health Care, which is a Bureau of the Health Resources and Service Administration, HRSA. That particular bureau currently provides assistance to more than 24 million poor and medically underserved Americans throughout the health center program. As a National Association of Community Health Center leader and Associate Medical Director Officer, he serves as a lead for the clinical workforce and the integration of oral health with primary care. Dr. Weaver began his career in the U.S. Public Health Services in 1975 as a National Health Service Corps volunteer physician. After his service in Tookooloo, Utah, Dr. Weaver served in HRSA's regional and central offices in positions of increasing responsibility and subsequently served as the director of the NHSC program for 15 years. He has been awarded Distinguished Service Medal, the Service Medal as the Surgeon General, the Surgeon General Exemplary Medal, the Service Medal in recognition, all in recognition of his achievement. Dr. Weaver is also a diplomat at the American Board of Family Medicine, and he's coming to us today with some comments. Don, thank you so much for being here, and thank you for representing the National Association of Community Health Center.
Sandra, thank you very much for that kind introduction. On behalf of the National Association of Community Health Centers, I want to welcome this year's GE-NMF Primary Care Leadership Program Scholars to the Health Center family. And I want to thank the GE Foundation and National Medical Fellowships for the opportunity to dialogue with you today. I've been asked to speak about America's health centers, history and progress, and those of you that know me know I like to talk about history with stories. So let's begin with a story. Let's begin with a fourth-year medical student some number of years ago now at Case Western Reserve, which was what the medical school was called at the time, who through a very interesting sequence of events arranged for an experience in South Africa to learn with and from Drs. Sidney and Emily Clark, a husband and wife team who had developed this health center concept in Phalela, South Africa, about community-oriented primary care. the brief notes about community-oriented primary care. It's really a bridge between clinical medicine and public health. It's about caring for a population. It's about determining the needs of a community. It's about selecting a need or needs to address, and then evaluating how well those needs were addressed and what needs to be done next. And last and not least, but most importantly, along every step of the way with community involvement and the community driving each step. As many of you may know, that medical student's name was Jack Geiger, and Community-Oriented Primary Care, or COPC, has served as the foundation for the health center movement in the United States. So from that student experience, let's jump to 1965. Grounded in the civil rights movement with large support from the faith community, Dr. Jack Geiger and Count Gibson began the health center movement. The first two demonstration projects were part of President Johnson's War on Poverty. The demonstration was funded through the Office of Economic Opportunity. Now, depending on where you're from in the United States, you like to say you were the first health center. If you're from the Northeast, you'll say that Columbia Point Health Center in Dorchester, Massachusetts was the first health center. If you're from the South, you would say that Delta Health Center in Mound Bayou, Mississippi was the first health center. And as I'm fond of saying, having competition to be the first of what's evolved into an amazing system of care across the country is just fine if they both want to step forward and say they were the first two. There were some interesting comments from Dr. Geiger at that time. One of them was, he noted the poor get sicker and the sick get poorer. And he followed that up by saying poverty-causing conditions must be addressed before the health of a community can be sustained. Dr. Geiger was way ahead of his time in the social determinants of health. I guess another story, a very brief one, talks about his commitment to those social determinants of health. It was down in Mount Bayou that Dr. Geiger wrote a prescription for food. And a federal reviewer came by and indicated to Dr. Geiger that that was not what prescriptions were for. Dr. Geiger's response, I was taught you wrote prescriptions for what people needed to improve their health. Taking even the next step in Mississippi, they also obtained land, for so many of the people they saw at Delta Health Center had incredible agricultural skills, but no land upon which to use those skills because they were sharecroppers. So with that land, they could grow their own food, one step better than getting a prescription for food. From those first two health centers in 1965, health centers began to expand, Denver, Chicago, New York. And by 1971, there were over 150 health centers across the country. I think the good news about the health center story is the health centers have enjoyed support from both sides of the aisle over the years through a series of presidents and different administrations. That's not to say health centers haven't been without their challenges. There have certainly been those who proposed to take all the funding that was going directly to the communities and block grant net funding to the states. There were others who proposed to decrease or eliminate funding. But throughout it all, health centers have adapted to change, and they have been sustained by their mission. The term health centers that we use now in a somewhat generic sense includes four groups of health centers that are funded under Section 330 of the Public Health Service Act, sometimes why they're called 330s. Community health centers, migrant health centers, health care for the homeless health centers, and primary care in public housing health centers, all consolidated into one part now of the Public Health Service Act. Actually, the very first of those, if there's a quiz question you want to ask, were migrant health centers, because the Migrant Health Act was about 2 years before the demonstration funding for the first two community health centers. You'll also hear health centers referred to as FQHCs by many. FQHC, Federally Qualified Health Center, is actually a term from the Center for Medicare and Medicaid Services that refers to how an entity is paid rather than specifically referring to health centers. As you heard in the introduction, health centers are currently serving over 24 million people at over 9,200 locations across the country. Each location adapted to that community, but all committed to providing accessible, quality, culturally and linguistically appropriated health care. seeing everyone without regard for their ability to pay, that is, having a sliding fee schedule to make sure that finances are not a barrier to health. And as they were from the teachings of the CARCs, are community-driven. Not less than 51% of the board members that are responsible for the health center, not less than 51% are patients of the health center. In addition, health centers serve as economic engines for their community, and for you and others, they provide career development opportunities. Dr. Geiger is fond of relating stories of not only the success of improving health of people, but from individuals from communities served by health centers who have risen through the ranks and now are the CEOs of the health center, or chief medical officers of the health center, are serving as a nurse in a health center or a dentist. They are real success stories and added-on successes of health centers. As you can see, health centers have a proud tradition upon which to build. And it would be comforting if we were finished with our work, but as I'm also sure you know, there is more work to be done to achieve health equity and to eliminate health disparities. I consider it a privilege and pleasure to be involved with health centers. What can be a more noble calling for anyone than working with organizations that are committed to improving the health of underserved communities and vulnerable populations? And back to those COPC roots, healthcare being driven by the patient and by the community. We hope each of you has a GE-NMF Primary Care Leadership Scholar Program experience that is a time of personal and professional growth, for you are helping carry the health center torch to light the fire of hope in the communities you are privileged to serve. Thank you.
Don, thank you for those exceptional words to our new group of students around lighting that fire to carry the community health center and their focus, and hopefully having new members of the community's health center going forward. It is now my honor and privilege to introduce you to Mr. Gray, Mr. Bruce Gray, who's the Chief Executive Officer of the Northwest Regional Primary Care Association. Mr. Gray has a rich background in community health at both the federal and the regional level. He started his community health career with the U.S. Department of Health and Human Services, the Bureau of Primary Health Care, Division of Community and Migrant Health, back in 1995, ultimately serving as a special assistant to the DCMH director. In 1999, he returned to Seattle, Washington as the Northwest Director for Capital Link, a national consulting firm for healthcare facility development, and 5 years later, he accepted the CEO position at the Northwest Regional Primary Care Association. This is an association of 80-plus communities and migrant health centers in the state of Alaska, Idaho, Oregon, and Washington. Mr. Gray has served on various boards and committees, including as chair of the National Association of Community Health Center Program Planning Committee for 4 years, and as vice chair of its Farm Work Health Committee for 2 years. And for the past several years, he has served on the United Healthcare National FQHC Advisory Committee. Mr. Gray holds a Master of Public Administration from the University of Washington Evans School of Public Health Affairs and a BA degree from Brown University. He will discuss community health centers and healthcare intervention. Welcome, Mr. Gray.
Thanks, Sandra, for the very nice introduction. And also I want to thank both Esther and Joy for the invitation to join today to talk with you all. And to echo Esther's congratulations to all the scholars on the phone today and the upcoming adventure you're going to have. So it's terrific to have you all in the program. I just wanted to touch base on really 3 different aspects of health centers innovation. And Don's done a nice job with the first, really around the past. The second area really being the present, what we're currently engaged in, and some aspects of the future and how health centers and the opportunity to innovate, what that offers us coming up. On the first part around the past, And again, Don has touched on the notion that the health center model itself is a fundamental innovation that came out of the Kirk's work in South Africa in the 1940s, and following that, really that bridge between primary care and population-targeted public health interventions, looking at things such as sanitation, nutrition, housing. And so in a sense, the very origins of the health center model are an innovation in and of itself that really led to, I think, some terrific developments in the 60s, 70s, and onward. The second piece of that is that not only is it in the model itself, but it's in our DNA. It's a phrase we often use, that to adapt and to innovate has been part of our history and the requirement for us to address the issues and the conditions in each community. That's very much part of our founding mythology. And Don shared that nice story about the docs at Delta Health Center in Mississippi doing emergency prescriptions for food and charging those costs to the pharmacy. And that's something that's always motivated both myself and a number of the rest of us in the health center world to think of innovation, as Dr. Geiger did in those early days of the health center movement. So if you all are interested, there's a terrific study that came out from the Institute for Alternative Futures that talked about CHCs and leveraging the social determinants of health. And it cited some of the examples across the country that in the first 50 years of the health center movement really have brought in that innovative approach to developing the strategies for individual communities. And I'm just cite a few. The Beaufort, Jasper, Hampton Comprehensive Health Services in Ridgeland, South Carolina. It's a terrific model of looking at some of the sanitation issues, the notion of clean water, developing that and recognizing that that's fundamentally part of health and health care, and we needed to incorporate that. Similarly, 16th Street Community Health Center in Milwaukee saw a challenge and issue around brownfield concerns in their community, environmental cleanup and environmental engagement, and did that. There's also a health center in Kansas City that when they looked to expand out their health center facilities, recognized when they went to the community, recognized that the real need in that community was for housing. Consequently, they developed an affiliate organization called Community Builders of Kansas City that then helped build that kind of housing in their community to really look at long-term sustainable development. That then led to getting an anchor grocer to come in and revitalize an entire community area around economic development. So you can see it ripples when the health centers get engaged in all these different aspects of healthcare and community development, and that's very much been the history. So from the past, I want to segue to the present. And the key piece here, and the term I'll use is from that movie, Back to the Future, is that we have an opportunity now within the health center world to truly engage and recognize the opportunities that Dr. Geiger and Count Gibson and others founded the health centers in the 60s around. And the reason for that is that much of the efforts around healthcare innovation and healthcare reform in the last 10 years or so, and particularly with the ACA, the National Health Reform, have been around the triple aim. And the triple aim that came out of the Institute for Healthcare Improvement has three key parts. One is improving the patient experience of care, and that's including both quality and satisfaction. Two, improving the health of populations. And three, reducing the per capita cost of healthcare. So you can see the sequence of looking at how are patients experiencing the models, what are the outcomes that are coming from those improvements in healthcare, and then how is it impacting the cost piece. So with that in mind, and the changes that have been happening both at the national level and at the federal level, there's been a push to really change the payment methodology, to move from what we refer to as volume-based payment, and that's really around the fee-for-service, to more value-based payment, and that notion of accountable care. And accountable care in certain forms has taken on the approach of accountable care organizations. You all might have heard the term ACOs, and in each state it's a different translation. For example, out here in Oregon, we have what are called CCOs, coordinated care organizations and communities. But the aspect really is how can different partners in healthcare, from tertiary care to primary care to public health to those entities that are involved in the social determinants of health, come together and really determine with a single budget the best health outcomes they can achieve through that coordination of care. So it's really paying for health outcomes and health itself rather than just for health care and the services that go to that. So with that change, there's a very exciting opportunity to look at how the history of health centers and innovation can assist, and we can pivot off that to what we're currently working on. And I look at a few areas around holistic healthcare. Health centers from the beginning have been very interested in integrating primary care with oral health, with behavioral health, more recently with vision care, really looking at the entire body in a sense of where do we see the aspects of oral health that are so impactful around individuals coming in for their primary care, and where can we have a dialogue at the primary care level of assisting in oral health. Similarly with behavioral health, the adage of when was the head disconnected from the body. And I think we're really moving back to seeing all these pieces tied together. Similarly, around enabling services, health centers have always recognized and done what they can, and this goes back to the story that Don shared about Dr. Geiger, around what are the areas that can support the primary care piece, the medical care piece. And that goes back to that image of medical care being, often you'll see the chart, 10% of some of the health outcomes. We really do need to look at all the elements that contribute to health outcomes and how we pull those partnerships together around that. So the enabling services are another critical area that have really led to the kind of innovations around this. Then similarly, there's a term we use called going upstream, and that's really around the prevention pieces and how we're not talking about only health, but health, wellness, and well-being. And well-being also often gets into that area of sense of community, and sense of purpose, and how individuals can feel very grounded in their communities and in their own futures and to contribute to their own health. So that notion of going upstream is really around a collaboration, for example, between public health and primary care. And they're a national group called ASTO, which is the Association of State and Territorial Health Officials, has had a very exciting project around the integration of public health and primary care. Similarly, and Duke University has been very involved in that too. You also can look at where the partnership between the hospitals and the health centers has really looked to broaden out that notion. And many of you may have heard the term community health workers and how we are being more proactive in getting out into the community and not waiting for folks to come into the four walls of either the primary care facilities or the tertiary care. And so you look at things like emergency room diversion and hospital admission and readmission issues and how we can partner together around that. So that's another area where a very exciting development that's encouraged by this accountable care model has come about. So you think about the behavioral health, the oral health pieces, the enabling services becoming more coordinated between public health and primary care, and looking at it from a systems point of view, all this is leading to then partnering more effectively with the social determinants of health folks, the housing, transportation, nutrition, education. That really is getting at community development in a 21st century way. We also historically have had things such as our health collaboratives, which in the late 90s and early 2000s really looked at innovative ways to approach chronic disease management, such as diabetes, and how that then built to some of the exciting programs. And I'm sure one here in the Seattle area that's called Global to Local. That's a partnership of our community health center, one of our community health centers here, HealthPoint, and Seattle King County Public Health, as well as Swedish, one of the hospital systems here, and looking at where are their global practices around community health that we can bring in to assist in a community that actually has a large immigrant population from around the world. So it's being proactive and thoughtful in that area. Similarly, we've got a health center newly opened here in the Seattle area called Meridian Health that is a combination of Neighbor Care, another one of our CHCs, the Seattle King County Public Health again, and one of the community mental health centers that have come together to co-locate. So part of it is how do we co-locate these different partners and facilities, but how do we then move that integration beyond co-location to a true integration overall? I just want to touch quickly on the present piece here in terms of workforce. And there's also been very exciting developments and innovations around workforce. And Don, in his prior life, heading up the National Health Service Corps, is largely to thank for establishing some of the key pieces that we're now moving forward with. One of them, for example, around medical home is team-based care. And that, in effect, I think is where the role you all have as scholars, looking at this next, this experience you're going to have over the summer, is really understanding the role you can play as leaders in team-based care and in that patient-centered medical home model. And similarly, as I mentioned, with community health workers, and where partners in the team can also be engaging out in innovative outreach practices to do that. And then similarly, at the federal level, there is the Teaching Health Center program, which is now has been funding a number of health centers in recent years, just over the past 4 or 5 years, to provide educational, the residency component to educational piece at an outpatient health center itself. So there we're really looking at innovations within the graduate medical education, within GME, that can assist in getting the workforce we need around primary care and a true medical home, and the base for a medical home that can then serve in the referrals out to specialty. So the last piece I just want to touch on here quickly is around the future. And there I'd like to use a phrase from William Gibson, who is an author that some of you might be familiar with. And he used a line that has always been a bellwether for me, and that's, "The future is already here. It's just not evenly distributed." And what he meant by that is that many of the most innovative practices are emerging around the country, whether in community health and in tertiary care systems. And often it takes years for those to reach a greater spread and to become more nationally available. But many of those practices are already emerging and have already emerged. So part of innovation is catching where there are those exciting developments and finding how we can foster those, we being the health centers and our partners across the line. And here I just want to touch quickly on a couple of elements around that. As I mentioned, payment reform and some of the exciting shifts that are happening around moving to value-based pay offer opportunities to be very innovative in how we pay for those services. Similarly, there have been some very exciting therapeutic advances in terms of the care model itself. And one of those that we're involved in here, and I know other partners around the country are, is in addressing what's called ACEs, the adverse childhood experiences, and recognizing where the impact of such adverse experiences in the home for that very early age, that 0 to 5 age group, has very profound implications on the physiology for individuals and their adult health outcomes much later on. And it's one of those areas where I feel very strongly that health centers and our partners can fundamentally change the game, in effect, of healthcare if we really look carefully at that and addressing that those early childhood elements, as well as the impact those have in adult health outcomes. So think about all the different areas of the therapeutic advances around the therapeutic model. Similarly, that term disruptive technologies. And there are some, as you all know, very exciting developments that are happening in terms of non-invasive biomonitors, how individuals can really track their own physiology, blood pressure, blood chemistry, whatever it might be. And then similarly around the technological advances, also looking at some of the management, the wellness and disease management apps that are coming out in terms of allowing folks to really look at their own behaviors and the impact those behaviors have. Then on top of that, telehealth. And very exciting developments similar to one of the models is called Project Echo, which some of you might have come across and certainly will be, and this summer should come across in terms of very innovative practices to assist, in particularly in rural communities, with specialists and looking at issues using telehealth. And then similarly in terms of social networking and gaming, that our culture has become much more involved and proficient, particularly younger folks, in working around the social networking and the gaming and how that can tie into a very fun and engaging way of looking at our own health in that area. And then similarly, you look at the electronic health records and how, at this point, the fascinating opportunities we have to tie in our electronic health records and do a much better job of measuring the metrics, not only metrics around healthcare, but looking at metrics in the community such as air quality and other elements that might impact health outcomes in a very profound way. So if you add up these pieces and then you tie that in with the changing U.S. demographics in terms of the aging of our population, I think we'll have 60% will be more than 65 by the year 2025. And you look at the changing ethnicity in our country in terms of a growing Latino population, as well as our attitudes towards health and wellness and our technologies around that. Those are all the pieces that health centers historically have been very engaged in, very connected into, and it goes to what Don mentioned in terms of that 51% requirement around the health center board and participants from the community on that board. When we understand our communities and we understand how to engage not only in our communities, but each of us within our community, that's when you get to a very exciting element of true health, wellness, and well-being. So with that in mind, I'll go ahead and stop there, but would certainly welcome questions later on if we have an opportunity. So thank you for the opportunity to speak today.
Bruce, thank you for your overview, very detailed overview, and I suspect our students will want to, as we younger folks like to say, unpack that. But thank you for your detailed overview and reminding us as well, as we heard from Don Weaver, of the social determinants of health focus that came to us many moons ago, back in the 1940s, by our own Dr. Jack Geiger, who serves as a part of this committee. I'm going to keep moving because we're down to just a few minutes, and we've heard the history, everyone. We've heard the innovative approaches from Bruce, and now we get to hear from an individual who's been a part of this program, a student, and very excited to introduce you to what will be one of our final speakers, but certainly a significant speaker because she's going to talk about the significance of the PCLP experience. Gianna Ramos is a third-year medical student and part of the PRIME program as MD Master Program for the Nurtures. Her passion is to serve the underserved, so she is key to understanding the relationship between our GE Foundation and our Community Health Center. During her undergraduate career, Gianna studied biology and sociology because she was interested in science and in learning about how science and medicine were affected by society and the intersection of oppression that continues to exist even today. That experience reinforced that medicine was the perfect blend for her passion, for service, for science, and the people. Gianna is a 2014 PCLP scholar. She's a 2019 MD candidate at the University of California in Los Angeles. Gianna, please give us your comment. Thank you. Gianna, are you on? Okay. If she is not on, or maybe she's having some problems with making comments, I think this is a perfect time to go to questions from our new team to join us. You've heard again from Bruce and Dunn and sharing with us the social determinant of health. You've heard such words as triple aim, improving the experience, the quality for an individual, improving the health care and the per capita cost should decrease. You've heard our overall leadership team talking about how we can move forward. Yes. Is she there?
Hi. I'm so sorry to interrupt. I think that she is there. I think that some people are hearing her and some people are not.
Okay.
So I'm just going to ask Gianna, if you can hear me, if you could dial in using a phone, and we'll answer a couple of questions while you're doing that, and then hopefully we'll be able to get you on the line that everyone can hear.
Thank you very, very much. So as we kind of take a moment, let's stop and take a couple of questions. Do you have any questions in the queue?
I do, yes.
Perfect.
Let's see, what have we got here? So one student has asked if Mr. Gray could provide some references to some of the studies that he discussed in his portion of the presentation. Mr. Gray, would you be able to talk briefly about some resources students could turn to for more information on some of the facts that you shared?
Sure, absolutely. I'd be happy to. And I mentioned the Institute for Alternative Futures, the study they did called Community Health Centers and Leveraging the Social Determinants of Health. They've also done a study, Primary Care 2025, Public Health 2030. They're looking at future scenarios and some of the elements around that. So that's some additional details that would be helpful there. I'm trying to think what, in terms of the triple aim, in terms of the background, that's come out of the Institute for Healthcare Improvement, and I'm thinking we can maybe provide some links after the call for the different pieces. I'd be happy to provide kind of a breakdown in the different areas that I mentioned and where there might be links to additional information in each area. That might be a quick way to answer the question and get more information out there.
Great. Thank you so much for that information. And yeah, if you send those links to me, I will share them with the folks who are able to join in on the call. And now it looks like we've got Gianna here on the phone, so I'm going to turn it over to her so that she can go ahead and share her comments with us.
Thank you.
Gianna, are you there?
Hi. Yes, I'm there. Can you hear me?
Yes, crystal clear.
Okay, great. Sorry about the technical difficulties. Hello, everyone, and first and foremost, congratulations on being accepted to PCLP. Like was said, my name is Gianna, and I'm finishing my third year of medical school at UCLA, and I'm part of UCLA Prime in Los Angeles, California, and I'm excited to see that there's some UCLA and Prime students on the line as well. I wanted to start by telling you a little bit about my experience as a PCLP scholar, and then a little bit about how NMF has continued to support my endeavors. In between my first and second year of medical school in the summer of 2014, I was selected to be a PCLP scholar, and I had the opportunity to go to Nashville, Tennessee. I actually started my adventure by road tripping from Los Angeles to Nashville because I'd never been to many of the southern states. And when I got to Nashville, I began working at the Matthew Walker Comprehensive Health Center, a clinic that serves mostly underserved Hispanic and African American patients, which operates on a sliding scale model, one that doesn't turn away patients for the inability to pay. I had a great time at Matthew Walker, and I learned a lot about being a provider for a community that really needed it. As part of Prime, one of my career goals is to work in underserved communities, and I was really able to do that through PCLP. I worked with a pediatrician, Dr. Williams, who also happened to be the medical director of Matthew Walker, and Dr. Williams provided a lot of insight about the current state of healthcare in Tennessee, what it meant to be a pediatrician, and how to really impact the health of her community. Not only did Dr. Williams let me see patients in Nashville, but once a week she took me and the other PCLP students to Clarksville, a small rural town where Matthew Walker had a clinic that serves rural underserved patients. I had the amazing opportunity to see patients on my own and was given the opportunity to make medical decisions with the team both in Nashville and Clarksville. I also conducted a public health needs assessment while I was there that looked at the care that adolescent patients were receiving and helped to address the needs and wants of the adolescent population. One of the cultural differences that I saw in the care of adolescent patients between Los Angeles and Nashville was provider comfort in talking about sexual health with adolescents, and I really wanted to explore that. I used the data that I collected to create a booklet for the providers at Matthew Walker so that they could better serve their adolescent patients in the future, ask perhaps difficult questions, and provide resources for those patients. For me, PCLP was a huge opportunity to do a couple of things. First, to travel to a city that I had never been to and experience the healthcare system there, to work with patients almost daily as a provider and as part of the healthcare team, and to look at a specific health-related topic I was interested in addition to forming relationships with other students who were interested in the same kind of work I was, specifically looking beyond physical ailments and exploring the social determinants of health. In our PCLP group, we had students from Chicago, Nashville, Atlanta, and LA, so we brought our own unique experiences and perspectives to the clinic. Since that time, I've truly become part of the NMF family. I was also awarded the NMF Aetna Healthcare Leadership Scholarship in 2015, and I'm currently working on a project in a high school in the Boyle Heights neighborhood of East Los Angeles as part of the California Community Service Learning Program Scholarship in 2016. NMF has a number of scholarships and service learning programs similar to PCLP that can continue to support your desire to impact the communities you want to work with. And NMF truly understands how challenging it can be to be an underrepresented minority or socioeconomically disadvantaged in the medical field. I've been to a number of events as a result of my work with NMF, and it's great to see physicians of color and humble beginnings who want to mentor people like us. So again, congratulations on becoming a PCLP scholar, and welcome to the NMF family.
Hello, Jen, are you done?
Yes, I am. Thank you.
Okay. Thank you very, very much for that oversight and input around what you bring to the table. So let's go back to our question and answer period. We're down to about 9 minutes. We want to make sure that we're able to answer all the questions of the new individuals joining our PCLP team. Questions, anyone?
Yes, we got one more practical question from one of our participants who asked if the slides will be sent out. And yes, if you're interested in receiving the slides from this presentation or the bio information about the presenters, feel free to reach out to your PCLP contact after the webinar, and we'll go ahead and send that information to you. Let's see what. I've got a few more questions popping up, but if anyone has any additional questions, feel free to chat those. One student has asked, Gianna, how did you go about becoming a part of the community at your site placement, given that you were there for a short time?
Yeah, that's a really great question, and I think the easiest way to do that is get to know the people at your clinic site and work with them, because they really are already part of that community, but they are welcoming you as part of their staff as well. And so I got to know the nurses and the PAs and the other physicians and medical students, and I think that once you kind of all work together, the community sees you as one sort of provider team, and so, you know, I assimilated fairly easily into the community.
Great, thank you for that. Let's see, another scholar asked to Mr. Gray, as a student, how can we begin building partnerships with organizations in fields outside of medicine, i.e. dental, behavioral health, et cetera, to bring these types of care into primary care practice? Mr. Gray, what are your insights on that?
Sure, that's another great question. I'd love, Don, you also weigh in on this one too. I think the first thing is even just the awareness, and that you all are, by the question, interested in doing that is a great step in the right direction. And then based on the experience you have at a health center and finding out where there are partners that they're working with in that community. So clearly, whether it's in dental health or behavioral health, if that health center is partnering with other entities, co-locating care or integrating care in some other fashion, there's definitely opportunity there, and ask if they can learn a little bit more about the partner that's providing that care. It's similarly around the social determinants. I think there are many of the centers are involved in conversations in their community and in partnerships in their community that have them sitting down at the table with folks from the housing industry, from nutrition, and looking at some of what we call the food deserts. Are there opportunities to get better food produce coming through? And so there, I think the key thing is with that interest that you have and with that awareness that the models really are moving towards more integrated and comprehensive care across the systems, as Dr. Geiger really envisioned and the Karks envisioned back in even the 40s, is asking about and seeing if you can, engage with the folks from those partners in the communities you're in. And certainly, again, I'll provide links to some of the innovations in these areas that are coming with that information. Certainly feel free to share those with some of the folks at your health center, at the partners. We want to make sure we're keeping information flowing in terms of what our best practices across the country in creating these the accountable care type of connections and moving health care to that level of true, again, as I mentioned before, health, wellness, and well-being. So I'd be happy to provide other information. And, again, I think the very nature of the question you're asking indicates that the kind of awareness is the first and most important step.
Other questions? We have time for probably one more question.
Sure. One scholar has asked, do any of the panelists anticipate issues with moving towards value-based pay for primary care physicians as a part of focusing on patient health outcomes?
Don, why don't we start with you and Bruce? Let's start with Don and then Bruce, and then we'll end with just a few comments from me. Don?
Thank you. And to sort of put an add-on to what Bruce had to say, as you look and ask questions about oral health and behavioral health and integration, in particular for oral health, a couple of great resources are the National Interprofessional Initiative on Oral Health, which has put together a curriculum for the care team members that are dentists, but also particularly for physicians, PAs, nurse practitioners, called Smiles for Life. And also to call your attention to the National Center for Interprofessional Practice and Education, because I think increasingly, and it really leads into this question, I think increasingly that is going to be our answer. As we move to paying for value, not volume, it's going to be about who can, in my favorite principle of the patient-centered medical home, who can work at the top of their licensure training and our certification, and allowing everybody on the team to do what they can do. I think that's the direction we're moving. We really are in that no person's land between the no longer and the not yet, save for some demonstrations. But I don't believe it's an if, it's really a when we will get to value-based care, which is in the best interest of patients' health and the community's health.
Thanks, Don. Mr. Gray?
I would just echo what Don said. I think that's really, we're trying to determine what really are the best ways to achieve accountable care and move from that volume approach to more the value approach. And I think there's what I would just say, with your perspectives, the scholars on the phone, and over the next period of months, as you see opportunities to contribute to that, please share those with the folks you're with at the health centers and also with the program here, because you have a way of seeing what's going on the ground that's much fresher and can really contribute to making value-based care models work.
Thank you very much. Want to personally thank GE Foundation, Jennifer Edwards. Want to thank Bruce Gray and our Dr. Dunn Weaver for their leadership and comments on today. I believe that question is going to be ultimately answered by those of you who will be a part of our primary care leadership program. Getting to value-based healthcare, focusing on the outcome of healthcare, is certainly turning a large system in a different direction. And I hope each of you, as you not only join our program, but as you go into your career, that you're very excited about the opportunity to focus on outcomes. On behalf of the National Medical Foundation, our GE National Medical Foundation Primary Care Leadership Program, and each of our speakers today, we want to thank you for joining us on today and look forward to continuing to work with you to make sure that you're the best primary care leadership as leaders in the country as you focus on our primary care leadership program. Have a fantastic rest of the day. Look forward to talking with you soon and seeing you in Chicago. Thank you. That's the end of our conference on today. Thanks, everyone. Have a great afternoon.
Great. Thanks, Sandra. Thanks, everybody.
Thank you.
Bye-bye.
Bye-bye.